Good morning, everybody. So we are about to start this CSI master class. This is perhaps the number 6 such classes we are holding. We will have two things today. First, there will be a case presentation, a case of chronic coronary syndrome to be presented by Dr. Abhishek from BHU. And to examine him, we have a panel of 4 eminent examiners, Dr. Satyen Tiwari, Dr. Sandeep Bansal, Dr. Justin Paul, and Dr. Shouro Mukherjee. I think without, it is already past 2 minutes past 11, so without wasting any time, may I request Abhishek to start sharing your screen and start the presentation. Abhishek.
Okay, sir. I'm sharing my screen. Sir, is it visible?
Yeah, it's visible.
Okay. Thanks to all respected teachers and organizing committee of CSI and to give me opportunity to present a case here. I have presenting a case. This patient, 48-year male, resident of Robertganj, Varanasi, Uttar Pradesh, is advocate by occupation, educated in a postgraduate MA, and he given history by himself with the chief complaint of chest discomfort since 6 months. This is the only chief complaint he had. History of presenting illness. This chest discomfort is for 6 months. It started in month of October 2020. Initially, it is insidious in onset and gradually progressive from Canadian Cardiovascular Society grade 1 to 3. Initially, the chest pain is in mid-chest region. The patient initial days feels heaviness around the chest on walking around 2 kilometers while jogging with strenuously or rapidly or climbing stairs, carrying some heavy objects like a bag of vegetables and bucket of water. And this heaviness is subsided by taking rest within 5 minutes. Initially, he ignored this discomfort for about 2 months and did not visited any physician. After 2 months of symptom, he started feeling of heaviness while walking for around 500 meters. And this time the heaviness typically
can we interrupt him right now?
Anytime. It is just like an exam. Whenever you feel like, you can interrupt and ask.
So Abhishek,
time is 1 hour, so you divide the history, physicals, and the investigations accordingly.
Right. So Abhishek, if you come back to the previous slide, you say that you started, you graded this patient's condition according to the Canadian Cardiovascular Society.
Yes, sir.
In the Indian perspective, how do you decide that this is CCS 1, 2, or 3?
Sir, in Indian scenario, like patient is graded Cardiovascular Society, like patient if having chest discomfort with minimal exertion, if chest discomfort with strenuous exertion.
Then I will ask you, tell me the criteria for Canadian Cardiovascular Society.
Sir, if the patient having chest pain and angina, then we are graded in 4 grade 1, grade 2, grade 3, and grade 4. And in grade 1, patient having chest discomfort with strenuous activity. In grade 2, patient having chest pain with chest discomfort with moderate activity. In grade 3, patient having chest discomfort with minimal activity. And grade 4, patient having chest discomfort or chest pain with at rest.
What is the difference between Canadian Cardiovascular Society classification and the NYHA classification?
Sir, NYHA classification is also a functional classification for characterizing the cardiac symptoms like chest discomfort, palpitation, fatigueness, and dyspnea on exertion. It is also
CCS, according to you, is also a functional classification.
it is a classification of basically the grading of angina, sir. Grading of angina. We can grade it as.
Okay, go on. Let us go further.
One point, Vishek, in NYHA also chest pain is one of the components.
Yes, sir.
So that can also be graded.
Yeah, we can also use that.
So the question was, what is the basic difference between the two? This is only for angina, and here we have 4 symptoms, which is classified. Anything else?
Sir, NYHA classification can also be used for various other symptoms like.
Yeah, that's what I said, that there are other symptoms which can be classified by this. Dyspnea is the most predominant one.
Yes, sir.
What is ordinary physical activity has not been defined here, whereas in CCS classification, it is well documented and well defined that this is the amount of exercise you do to say that this is CCS 1, 2, 3, and 4.
So initially that patient having CCS grade 1 because he feels chest discomfort on strenuous activity or when he walks rapidly. Rapidly beyond the ordinary activity. Then
okay, you proceed with your history.
The prime difference is one, it is classified at this specific activity is specifically mentioned in CCS, and the second part of it is emotional aspect is given importance in CCS, whereas it is not given importance in NYHA. That's it.
Okay, sir.
Yeah, you actually have well-defined criteria. That is why I asked you, because they are defined according to the Canadian criteria. You walk so many blocks or more, and you get angina. Now those blocks are well defined. They are 1 kilometer in the Canadian perspective. You may not have well-defined blocks in the Indian perspective. The only way you can actually equate is by the flight of stairs. Typically, what you will find is that if you try to convert it into our own setting, the only way I found that one can do it is by using the flight of stairs criteria. If you can climb more than 2 flights of stairs, then it is CCS 2 essentially. But if you get breathless between 1 and 2, it is CCS 3. That is the equivalent conversion that I could find. Otherwise, there is really no way when we say CCS 1, 2, or 3, of 4 of course is at rest. So it is quite empirical. That is something that we must be aware of in case of the CCS classification. And so it is kind of semi-quantitative. It is not exactly functional classification. It is a semi-quantitative classification with a well-defined criteria. And secondly, by convention, whenever it is only angina and no associated other symptoms, fatigue, palpitation, or dyspnea, when they are not there, then we don't use NYHA. By convention, we use CCS for angina and we use NYHA for when more than one symptom are present. That is my take on it.
Go ahead, doctor. Go ahead.
Please go on, please.
Carry on.
After 2 months of this symptom, he started feeling heaviness in chest when he walking around 500 meter, or at this time he feels chest pain, particularly during activity like walking, climbing stairs, or during heavy object.
Yeah, we understood that. You can move forward.
And this pain radiated towards the neck area and left arm. By resting about 10 minutes, he got relief. There is no rest pain. Yes, sir.
May I interrupt you?
Yes, sir.
So you said that it needs about 10 minutes to get relief from the chest pain. So
Yes, sir.
initially he was walking for about 500 meters. He's pretty comfortable. So do you need so much time to get relief from the chest pain after taking rest? So it's badly 2 or 3 minutes he should be feeling relief from that.
The
10
patient,
minutes is a long time.
but patient described he relieved from chest pain gradually within 10 minutes.
Within man, there
Within
should be an
10
average time. It should be 1 to 2 minutes because he's walking. He knows to what extent his activity has to be restricted before he cannot continue walking further. So the moment he is starting to have chest pain, normally what they do, they just stop walking,
They just
and
stop.
they should be getting immediate relief, isn't it?
Yes, sir. It is, but patient describe as like he.
Okay, you are describing as a patient has said. Let
Yes,
us
sir.
continue. Okay.
There is.
Can you tell me what is Levine sign? Levine, whatever I call it, Levine sign.
Levin sign, it is
Justin is showing you.
Levin sign is a heaviness that felt around the chest.
I was going to ask you the other way. I was going to ask you, how did the patient describe his chest pain? Did he clench his fist on the chest, or did he move an open finger up and down the chest? How did he describe the pain?
Sir, patient described chest pain as a pain around the constricting pain, squeezing pain, or heaviness type of pain around the chest, or
Okay.
So
Go
there
on,
are,
please.
so there are 5-6 points which favors it is anginal or non-anginal. So what would be-
second thing is this pain also feels around the neck, jaw, shoulder, or arms, and this pain is precipitated with exertion and relieved by taking rest or taking nitrates within 5 minutes.
So you think it is angina?
Yes, sir. The patient described
Okay.
typical angina.
Okay.
There is
Proceed. We won't be able to finish that.
there is no rest pain, no nocturnal pain, no postural variation of this chest discomfort, and no circadian variation. He called a family physician at this time, and the family physician advised him a medicine to take sublingually. After taking that medicine, he got relief every time, and he did not bother to go to any physician. After 5 months of initial symptom in February 2021, his condition got worsened, and he started feeling heaviness in chest while doing his daily routine activity like taking bath, putting clothes, and chanting mantras during puja. And this heaviness persists for about 10 minutes and subside gradually on taking rest or taking that pills sublingually. He also feels heaviness around after taking heavy meal sometimes, and for this worsening symptom he came to cardiology OPD in BHU.
Is there any importance of this feeling heaviness after heavy meal?
Sir, the angina after meal or postprandial angina is indicative of severe form of disease, or it indicates severe stenosis.
Okay.
There is chest discomfort was not aggravating on deep inspiration, or no postural variation is there. Chest discomfort was not associated with diaphoresis, dizziness, nausea. There is no local swelling around the chest, and chest discomfort not associated with cough, expectoration, dyspnea, and fever. Also, syncope palpitation is not there, and no lower limb swelling. there is no history of nocturnal angina, no history of orthopnea or paroxysmal nocturnal dyspnea.
Why did you ask the history of syncope and palpitation?
Sir, syncope and palpitation, I have asked because in case of like patient having HCM, hypertrophic cardiomyopathy, or a patient might present with syncope or near syncope, and that patient are also prone for arrhythmic event. So palpitation can occur in this
More
patient.
common cause than that for angina, syncope, and dyspnea, or even palpitation sometimes. What will be the more common cause, or commoner cause, I should say?
We can also rule aortic stenosis.
Right. So that should have been your answer to my mind.
No history of abdominal pain and diarrhea, and no limb claudication. There is no history of loss of appetite or dysphagia. Past history, there is no history of prior MI. Patient is diagnosed with type 2 diabetes and hypertension at the age of 36 years. And he was also diagnosed cervical spondylitis from 3 years, to which he used cervical corer sometimes. And there is no history of previous hospitalization. Treatment history, he was on oral hypoglycemic agent. As he is well educated, he named his medications. He regularly taking gliclazide 80 and metformin 500 milligram combination tablet, and tablet tinlagliptin 20 mg OD. He also take tablet telmisartan 40 mg for hypertension, and he also take tablet rosuvastatin 10 mg. And tablet sorbitrate 5 mg sublingual prescribed by his family physician, and capsule omeprazole 20 mg. This is the family history.
Just a minute. Just a minute. I want to ask you one question. You said that with the first medical contact, he was prescribed sublingual tablets. Okay. So he was not given any long-acting medications. So you said that after taking that sublingual tablet, he never bothered to visit any doctor, and he got relief from the pain. How is it possible?
Sir, second time, when he start feeling of heaviness around, initially he did not bother of initial symptoms. When he feels symptoms around walking around 500 meter, and then he called the family physician. At that time, he prescribed that medication.
But still, that medication he used to take only on the chest pain used to come on. So,
yes, sir.
But during walking, he still felt chest pain, isn't it? During walking, he couldn't walk that 500 meters any longer.
Yes, sir. Because that might taking the short-acting drug. That's why.
Yeah. So that should be on a regular basis in addition to the sublingual nitrate. He has to be given a long-acting nitrate or even sorbitrate tablet 1 to 3 times daily, isn't it?
Yes, sir.
Okay, carry on.
This is the family tree of the patient of 3 generations. His grandparents having 6 children, 5 are male, in which 1 is having diabetic and hypertension, who is a patient's father, and patient's father and mother both are diabetic and hypertensive, and have 5 children. 3 are males, 3 males and 2 females. And
how it is relevant? I think you better. Is there any history of premature coronary artery disease?
No, sir. No. In this family history, in successive 3 generations, there is no history of premature.
You don't do the family tree in all patients who are having diabetes or hypertension. While we deal with a case of coronary artery disease, you just go ahead.
Anyway, he already has diabetes and hypertension.
Yeah, that is enough. That is enough.
There is no history of premature cardiovascular disease in family. Personal history is married, taking mixed diet and normal appetite. There is no history of smoking, tobacco chewing, alcohol or IV drug abuse. His bowel bladder function is normal and sleep pattern is also normal.
How many
He
hours he sleeps per day?
is in upper middle class with modified Kupuswamy skills.
How many hours he sleeps per day?
He used to sleep around 7 to 8 hours.
Okay. Go ahead.
So this is the summary on the basis of history. A 48-year gentleman with known diabetic and hypertension, having angina on exertion, Canadian Cardiovascular Society grade 1, and progresses to class 3 within 6-month duration. And this indicates typical feature of angina. My possible diagnosis is first is ischemic heart disease, chronic coronary syndrome. Second, I kept the lower possibility hypertrophic cardiomyopathy or bicuspid aortic valve disease.
So, you will have to say first it is a cardiac pain or a non-cardiac pain. Now this is a cardiac pain. Now once you decide it's a cardiac pain, it's a coronary pain or a non-coronary pain. Now this could be a coronary cause of angina or a non-coronary cause of angina. Then you'll have to consider that as a differential diagnosis. Then it's a coronary, it's an atherosclerotic coronary or a non-atherosclerotic coronary. All these things need to come into your summary.
So Abhishek, can you one by one answer all these questions which Professor Justin has asked you? Clarify.
Sir,
It's a cardiac pain, right?
it is a typical patient having typical angina. That's why it is.
Okay, so it is anginal pain. Then next step, what he has asked? Coronary, non-coronary?
It is coronary, most likely coronary, because patient have typical angina that precipitated with exertion and relief with rest and taking.
Why not non-coronary? By the way, you have kept two possibilities as well.
Sir, non-coronary, like in patient with hypertrophic cardiomyopathy, there is also angina. Patient can also present with the typical angina due to microvascular dysfunction or due to increase LV, due to increase LV. There is LV hypertrophy in HCM, and that lead to increased demand. So the HCM patient also presented with the angina.
Why you said bicuspid aortic valve?
Sir, bicuspid aortic valve patient mostly present after the 50 year of age, and they
third decade. It usually presents symptomatic at third decade.
Third decade.
What are the other points which
they present? They present when there is a calcification in the aortic wall occurs. When it becomes severe, then angina pain occur in bicuspid aortic valve. But so it is a rare.
So this patient, does he has any other symptoms, significant symptoms other than angina?
No, sir. These other symptoms like dyspnea on exertion, dizziness, syncope, palpitation is not there. That's why we kept the possibility is less likely than ischemic heart disease.
Then sir has also asked whether it is athero or non-atherosclerotic.
Sir, it is atherosclerotic.
What are the other reason being non-atherosclerotic?
The age is 48. Patient is just 48 year of age.
About this patient, what are the non-atherosclerotic causes of coronary angina, or even ACS?
Non-atherosclerotic causes like patient having increased demand in case of patient having anemia, patient having primary pulmonary hypertension,
Non-atherosclerotic coronary causes.
non-atherosclerotic coronary, like a patient having coronary ectasia or coronary arteriovenous malformation or anomalous origin of left
L-kappa?
L-kappa, yes sir. L-kappa.
You see,
Have you
What
heard
is
of
Professor Mukherjee has asked a very important question. L-kappa, what are the two presentation of L-kappa? When it presents? Usually it presents very early.
It presents early and present with chest pain.
Right. When it presents, how can you say it is angina?
It
See,
presents
usually
during expansion.
they're mostly present with failure.
Yeah, that's right.
It is
So-
not chest pain. And these two things, you have already said this in the differential diagnosis, HCM and aortic stenosis. Dyspnea is a very important component of the history.
Yes.
You get chest pain with
Yes,
dyspnea.
yes.
So dyspnea is absolutely singularly absent here.
Yes.
And already you say the patient is hypertensive and diabetic. So these are the risk
That's
factors
why-
for atherosclerotic
Yeah.
coronary artery disease. So everything is pointing towards that. I think we should proceed. It is a
Yes, sir.
Yeah, please.
So you can go to the examination. Before that, in the general examination, in this patient, what are the things that you are going to look for?
We look for patient. We look for patient having typical angina. Then we look for examination
You have-
finding like
Angina. Yeah. Please go ahead. Yeah.
Dr. Paul is asking you what is Frank's sign?
what's it?
What is Frank's sign?
Frank sign.
Frank's sign. Yeah. Heard of earlobe freeze?
So, now that you know that you have a patient most likely having an atherosclerotic coronary artery
Earlobe.
disease.
Sir,
Yeah, earlobe freeze. Yes.
earlobe freeze is Frank sign.
Okay. What are the other things that you look for in general examination which could be helping you to narrow down the diagnosis or tell you additional causes of aggravating angina in the general examination? You will have to look for anemia. You will have to look for signs of thyroid disease. You have to look for a goiter. What are these things that you'll have? You should have in mind when you look for it. Anyway, you go ahead. Go ahead, doctor.
Chowdo, you are muted.
On general examination, patient is conscious, cooperative, oriented to time place person. He is well built with BMI 24.4 kg per meter square. There is no pallor, clubbing, cyanosis, icterus, pedal edema, and no lymphadenopathy. Skin examination, one important finding is there is dark velvety color patches seen on the neck and armpit, that is acanthosis nigricans. And pulse examination, pulse rate is 100 per minute, is regular, normal volumic. There is no radial or radiofemoral delay.
No xanthelasmas, no xanthomas.
Yes, sir. There is no xanthoma, no xanthelisma.
They become negative important findings you need to mention in a case like this. You may not have to mention a typical congenital heart disease or rheumatic heart disease, but when you're presenting a case of CCS, you will have to include all these things in your general examination. Go ahead, doctor.
There is no vessel wall thickness, no special character, and all peripheral pulses are palpable. BP is taken in supine posture. Right upper limb BP is 140 by 90 mmHg. Left lower limb BP, right lower limb BP is 150 by 90. Left upper limb BP is 144 by 90, and left lower limb is 150 by 90 mmHg. Respiratory rate is 16 per minute, thoraco-abdominal type. Temperature, he is afebrile, SpO2 is normal, and JVP is not raised.
Where did you check the low limb BP?
Sir, lower limb BP.
Which artery?
distal, that dorsalis pedis
Did you check?
posterior tibial artery.
What was the ankle brachial index here? Is it important?
Yes, sir. It is important to consider for peripheral artery disease. In this case, ankle brachial index is normal, 1.07.
And was there any bruit?
No, sir. There is no bruit in.
You need to mention that. You
What
need
is the, while we are on ankle brachial intakes, I agree with Dr. Justin, it's extremely important. So you please tell me about ankle brachial index. What is the normal ankle brachial index?
Sir, normal ankle brachial index is 1 to 1.4, and if it is less
I
than
would
1,
0.9 to 1.4. Okay. Go on. If it is more than 1.4, then
uh, uh, if it is more than 1.4,
okay, when do you start having claudication?
when ankle brachial index is less than 0.9.
And when do you start having rest pain?
When ankle brachial index is less than 0.5, then we
And
started.
when do you have CLI or critical limb ischemia?
Is less than 0.3,
Less than
0.3 or less.
Yes,
0.3 or less.
correct. So for every 0.1 decrease in ankle brachial index, the cardiovascular mortality increases by. Those are very standard questions about ankle brachial index.
Mortality increase
By 10%. So it's 10, 10, 10 all the way. For every 10% decrease in ankle brachial index, the cardiovascular mortality increases by 10%. That is fairly standard teaching. Okay, go on, please.
Systemic examination on inspection. Chest wall appears normal with bilateral symmetrical expansion. Trachea appeared to be in midline. Apical impulses seen in left fifth intercostal space or on the mid clavicular line. There is no visible pulsation, no dilated veins or scar. Palpation, tracheal position confirmed, and apical impulses palpated in fifth intercostal space left on mid clavicular region. It is normal in character. There is no parasternal heave, no palpable heart sound or thrill, no palpable pulsations. Percussion, right border correspond to right sternal border, left border correspond to apex, and left second intercostal space is resonant. Auscultation.
One question before you go to auscultation. Now the patient comes to you, he has rest pain. You are going to auscultate him. What are the potential auscultatory findings you could expect in this patient who has a rest pain, rest angina?
Sir, during whenever the anginal attack occurs, then we on auscultation we find S1 is soft at that time, and during
What is more important? What is more important than the soft S1? What is more common finding?
apical impulse.
No, we are talking
Auscultatory finding. That's what Justin Paul is hinting at.
You look at everything, S2, then added sounds, murmurs. If you go like that, you will not miss it. The S1 can be loud if there is a tachycardia related to that. Or S1 can be soft. Or if the patient has an intermittent LBB, you can have a split second heart sound.
Paradoxical.
Third heart sound.
If there is RBBP, then
systolic murmur of mitral regurgitation. These are the things that you need to have in mind when you auscultate. Go ahead, doctor.
auscultatory finding, S1 is normal, S2 is also normal in intensity with normal splitting. There is no murmur and no audible S4. Other system examination is also found normal. So summary after examination, 48-year male.
ask you this way, doctor. What has examination added to a historical conclusion? You had already come to a historical conclusion. What more did you get by examining the patient?
Sir, two things I have found on examination. One is acanthosis nigricans. That might indicate a patient having poor patient have insulin resistance and poorly controlled diabetes. And second, sinus tachycardia with 100 per minute.
You have got a lot of other things. You have excluded a couple of things, right? You have apical impulses normal, pulse was normal. You have excluded the severe aortic stenosis as the cause of angina. All the upper limb and the lower limb pulses were normal. So excluded an aorta arteritis or those kind of things that could cause the angina. They exclude a hypertrophic cardiomyopathy. These are the added information that you have already got by your examination. So if you know what you are looking, whenever you see a patient, you need to have in mind, this is what I'm going to look for in this patient, and these are going to narrow down my diagnosis. So now you have sort of excluded those valvular causes of aortic stenosis or subvalvular causes of aortic stenosis, which could be a potential cause of angina, which is the main symptom of your patient. Now go ahead, doctor.
This is the ECG taken on 10th March. It shows rate 135. Regular, axis is normal, P wave is also normal, QRS duration is 0.08 second, and no QT prolongation is there. And
do you think the first heart sound was normal when you examined the patient? The ECG was like this?
Sir, this ECG is taken when he comes from stairs, and at that time he is tachypneic, but after rest this subsides. After
the patient may be having a loud first heart sound if you auscultate him at this point of time.
Yes, sir. And in ECG there is a QS complex in V2 lead, and also RV is poor in lead V3. There is in 2-3 AVF, there is a downsloping of ST segment. Otherwise, no specific changes seen in this.
You have already done almost a semi-stress test in this particular patient. The heart rate went up to 140 or so.
Yes, sir.
So what is the height of the P wave in lead 2? I can't really see. Can you tell me? It looks little pointed up.
Right.
It is 2 mm.
Only 2. Okay, fine. So you need to really concentrate on the P waves, particularly the left atrial as the P terminal force in V1, particularly in the patients with angina, because they are going to give an indication as to whether the LV-EDP of this patient is likely to be elevated. So when you are taking ECG in a patient during an angina, this P terminal force in V1 could be more prominent. Please go ahead.
We have performed 2D screening echo at that time, and there is no resting regional wall motion abnormality. LV function is normal, 65%. Patient have grade 1 diastolic dysfunction, and but no regurgitation, no valvular regurgitation. IVC appears normal. Cardiac biomarker was also done at that time. CK, MB, troponin, and BNP. These levels are normal. This is the echo. Parasternal long axis. Leaflets are normal and no regurgitation. Parasternal short axis view shows heart left parasternal short axis view. LV is normally contractile.
But you showed something else also in the short axis. For a fraction of a second, the left main coronary artery came into the picture. It's always good to image the coronary artery in the short axis. You can see whether the origins are normal, so that you are not going to, if you are not able to see it, you should be prepared to look for an anomalous coronary artery when you are going to do the coronary angiogram. This is very important. In fact, you can pick up, if you optimize the setting of your echocardiographic mission, you can see the up to proximal LAD, and in fact, from the subcostal, from the apical chamber, you can even see the distal LAD. You can image the coronary arteries by transthoracic echocardiogram. You can see the proximal portion of the circumflex as well.
Okay. Sir, stress test is already done outside by and he showed stress test results, and he performed stress at stage 3 and with maximal heart rate 160 per minute, functional capacity 10.1 minutes, exercise time is 7.17 minutes and maximum ST depression is 2 mm. With this, we calculated the Duke treadmill score is -11 and it suggests high risk 1 year mortality.
Can you show the tracing in the TMT?
Sir, this is the stage 1. The baseline is not clear, but
see, with this baseline ECG, it is difficult to interpret, and as well, patients have a class 3 angina, you said.
Yeah, you don't
So
need.
what is the indication to get him a treadmill?
Correct.
someone, although the stress ECG is nowadays only recommended for risk stratification, sir.
In other words, what Professor Tiwari is asking you is, are there any indications for doing a coronary angiography directly without a stress test in a patient of chronic coronary syndrome?
Sir, in patient with chronic coronary syndrome, stress ECG is indicated for risk stratification, like function, like exercise. Look for exercise tolerance.
What Dr. Bansal is asking you is, can you go ahead with an angiogram without a stress test? What are the situations?
We can go ahead with the angiogram if patient having high likelihood or high likelihood.
No, you are not getting the question. What are the findings in the resting ECG which will lead you to do a coronary angio straight away and not a TMT?
If the resting ECG shows already ST depression more than 2 mm, if already in resting ECG.
So he asked you one, that patient is already CCS3. Did you need to do a stress test at all?
No, sir. Stress
Class 3 angina, it may not be very safe to put them on a treadmill. That is okay. The opinions may vary. Can you show the resting ECG before the stage baseline ECG of the treadmill? Go back.
Sir, that resting ECG is not
next one.
there.
Okay, stress ECG first one, stage 1. Okay, stage 1, show the stage 1.
This is stage 1.
There looks like some ST elevation in the anterior V1 to V4 during the treadmill. So, a baseline ECG will be very helpful to compare these things. Now, ST depression and ST elevation, which of these do have a localizing value for the coronary artery during a treadmill?
ST elevation of 1 mm or more in lead.
So, ST depression during a stress ECG does not have a localizing value. But if we have an ST elevation during the treadmill, it has a localizing value. An ST elevation V1 to V4 may tell you that there could be involvement of the LAD, probably proximal LAD territory. So these are some of the indications you're going to have before you put the patient on the coronary angiogram. Go ahead, doctor.
Just one last question. What is the current status of stress ECG as a mode of diagnosing coronary artery disease?
Sir, stress ECG nowadays is class 2A recommendation. It is only recommended when there is other non-invasive test is not available. Then only stress ECG is indicated. Otherwise, stress ECG is indicated only for risk stratification, like exercise tolerance. We look for arrhythmia event. We look for BP response, heart rate response. Only for that it is class 1 indication. Otherwise, it is class 2B indication.
Correct.
Doctor, according to European Society of Cardiology guidelines, they made it to a class 2B indication. Now you are sitting and practicing in India. As a cardiac scientist, you need to go beyond the guidelines. If you look at the references used in that guideline, they have used 3 studies to make that guideline as class 2B. They use CT coronary angiogram versus stress ECG, a stress echo versus stress ECG, and nuclear imaging versus stress ECG. And what they really found was, in fact, their stress echo charges are much cheaper than stress ECG charges. So in a country like India, you really need to understand what is the resources that you have, what are the facilities that your neighboring labs are going to have it, and use it accordingly. So I personally would not go, put all my money on the European Society of Cardiology guidelines of recommending a nuclear imaging or a stress echo for every patient in the areas where I practice. We have to understand the limitations of each, but you're a cardiac scientist. You have to go beyond the guidelines and look into the evidences used in the guidelines to come to that conclusion. Anyway, that is beyond this discussion. We'll move forward.
Yeah.
Yes, sir. This is the chest X-ray of the patient. It is more like having.
It's normal.
It is like tubular heart, and apical is rounded. Apical
So not significant. Okay.
Sir, coronary angiography was done at that time. Patient epicranial view shows.
Just sorry to interrupt. One thing, you didn't treat the patient beforehand. You didn't give any treatment. Patient had a pulse rate. Resting
Sir,
ECG, you have shown that the pulse rate is around 140. Patient was not on beta blockers, not on aspirin or anything. No antiplatelets.
Sir, this angio is done outside by the patient, and he came to our hospital.
What would you have done? What is the indication of
What should be done? What should be the methodology?
Yeah, actually, that was a very pertinent question I was wanting to ask right at the time he showed the treatment. What were the flaws in the treatment that you showed, and how would you have modified the treatment?
Sir, initially we directly did not go for coronary angiography. We first put the patient on the basis of presentation and examination. We stratify the patient on the basis of pre-test probability or clinical likelihood.
Abhishek, Professor Guha has asked you very straightforward. What treatment? 1, 2, 3, 4, 5.
First,
Before taking him to angiogram. Yeah.
We put on patient. We can put on beta blocker because already baseline heart rate is raised.
Just enumerate.
Beta blocker, calcium channel blocker as the first line drug.
You'll give what beta blocker, what calcium? Beta blocker accepted. What about the calcium channel blocker? Do you start with beta blocker plus calcium channel blocker? I think no.
No, sir. No, sir.
So you
Either
just tell
beta
me
blocker-
how to treat.
I start either beta blocker or calcium channel blocker, which is non-dihydropyridine group. And if patient did not respond, we aid the or did not respond to beta blocker or calcium channel blocker, or if patient have a persistent symptom, or if there is a non-tolerance to that drug, then we put patient on second line drug, which are that are most like that are long-acting nitrate, trimetazidine or ivabradine, renolazine.
I have one question for you. Have you heard of diamond approach to treatment of angina?
Nicorendyl group.
Diamond approach to treatment of angina. A linked question will be, is there evidences to show that these are first line drugs and these are second line drugs? Do we have evidences? Or it is based on expert opinion as first line and second line drugs?
Sir,
Abhishek, I'm sure you must have seen in your OPD such patients regularly. Okay. So you have to write a prescription. What you will write? Don't give explanation why you have. First, you tell me what treatment. One, you said beta blocker. We all agree. Second, you said calcium channel blockers. So there is a question. Why?
sir, we can aid calcium channel blocker, but regular monitoring of heart rate is needed. If we add if we are adding a non-dihydropyridine group of calcium channel blocker, and second line drug, obviously, if a patient not tolerated,
No.
then
First, you have to see the effect of the first line. Then you
Yes.
jump over, and you
Right.
also answer the question what
Patient-
Dr. Justin has asked. What he has asked. It is just to help you.
Diamond approach.
What is that approach? You know it.
sir,
It is okay, doctor. Basically,
Okay.
all these anti-anginal drugs are put in, 8 different groups, and you pick and choose what is more appropriate for your patient according to the his heart rate, his pulse, his BP, his associated risk factors. All these accordingly, associated clinical findings. You can choose any one or two according to the specific requirement of the patient, rather than going straight away by these are first line, these are second lines. They put all of them as the first line drugs. That's a diamond approach. Go ahead, doctor.
So you give beta blocker, nitrates, antiplatelet, statins, okay?
yes, sir.
And then oral, he's diabetic as well. And then you said for angiogram.
Yes, sir. Uh,
That's your final diagnosis.
sir, final diagnosis is
Yes.
is ischemic heart disease, chronic coronary syndrome, CCS grade 3, LVF 65%, with the grade 1 diastolic dysfunction, and there is a positive stress test. Risk factors are diabetes mellitus type 2, hypertension, and there is family history of CVD.
Also you have the angiography report, so you might as well put that in the final.
Invasive angiogram.
Instead of reading this, and just show the angiogram and
Yes.
read it fast. Okay. Which view? Which injection?
Epicranial view shows LAD is mid LAD is around 90% stenosis, and second diagonal is also disease at the ostium, 90%, and there
So
is
what
a
about the flow?
diffuse-
What about the flow in the LAD beyond the obstruction? Is it normal or reduced?
It is reduced TME2
Yeah,
flow,
that you should
and
mention, yeah.
and there is diffuse disease in the distal LAD. Epicaudal view shows plaquing in the proximal part of LAD.
And there is a calcium also in the proximal LAD as well.
Yes, sir, that is calcified, but non-critical plaque is there. LCX OM1 shows plaquing. OM2 from ostium, it is a disease, 90% and 80%, and OM3 is also diffusely diseased, around 70%. And there is a left dominance, it is left dominance circulation. In this view, caudal view, we clearly see the LAD. It is there is calcium in proximal LAD, which is non-critical, and mid lesion is 90%. stenosis. In RAO cranial view, we see we look the LCX. It is dominant and giving PDA, and PDA is also diffusely disease around 80% stenosis.
Just stop the injection of the left injection. See, what we are concerned as a operator, we have to make sure the left main ostia is normal or not, or it is disease. Not only the ostia, the shaft also. So the first injection has to be, you should look for which view? Iliocranial, 2550. So in one of the view, it looks there is some mild disease in the left main as well. Okay, and there is a ostial LAD involvement as well. Okay, and then there is a diffuse disease till the mid LAD, and it is calcified. Okay.
Okay, sir.
Yeah. Now show the RCA.
RCA is non-dominant diffusely disease from proximal to distal.
So what is your findings in coronary angiogram?
Sir, diffuse triple vessel disease.
No. Don't say triple vessel. Even a OM or diagonal may be one disease, you know. So you just tell what are the disease, severe disease.
Sir, LAD is proximal non-critical plaque along with calcification. Mid LAD is 90% stenosis. Diagonal one is having 70-80% stenosis, and D2 is also ostium from ostium 80 to 90% stenosis. Distal LAD is diffusely disease with TIMI2 flow, and LCX.
See, it may be diffusely disease or it may be underfilled. Okay.
Sir, TIMI2 flow, then we can't say that.
That may be because of the severe stenosis. It may be underfilled and appears like that. So it is little difficult to say that way, straight away that it is diffusely diseased.
But if we look for in RAO cranial view, there is also distal disease.
We are not saying that it is disease free, but still it may be have a mild disease. Okay. Because there is a severe stenosis at the mid LAD, so it may be underfilled also, unless you see a retrograde filling from RCA. So you have to see the RAO view of the RCA injection. So finally it has and there is a circumflex disease also. Okay.
Circumflex, sir, obtuse marginal 1 shows plaque.
Yes.
Obtuse marginal 2.
What else you want to tell in angiogram?
Sir, comment about the thrombus calcification.
Other than coronaries, you have to see what?
Other than
LV. LV is equally important, you know.
Left ventricular angiogram is a dying art, Satyen. So many people don't do anymore. Yes, right.
Because once you see, people, wants to save the time, the dye, whatever it is. But then if you do a 20 ml injection, it will be, truly shown picture. Because on echo, somebody say it is 35, somebody say 30, somebody say 40. But once you do it in angiogram, one should do it LV angiogram as well. Okay?
Okay, sir.
On echo, LV is normal, EF?
Yes, sir. LV.
So what's your plan now?
How will you decide the course of therapy? Whether can this patient be on medical therapy alone? Or does he need some intervention, surgery or percutaneous coronary intervention? How will you decide the treatment?
Sir, first we kept the patient on lifestyle modification along with medical treatment, and we see the response. Then if
see the response of what? That medicine?
Like angina, response for angina, and if patient doing well on medical therapy,
if he symptoms improves, you will put him on medical treatment?
Yes, sir.
no choice or no more concern for his severe disease in LAD
We can do
and
some
circumflex?
non- Sir,
It is not we can do. What is that you will do? You will
yes,
continue medical management if he is comfortable, or you want to do an angioplasty because there is a block there.
sir. Decision regarding revascularization. If there is a documented ischemia, then
No, you have done everything. Now patient is asking, डॉक्टर साहब क्या करेंगे? मेरे पेन अभी भी होता है, दवा खा रहा हूँ, वो कोई फायदा उतना नहीं हो रहा. He is just 48.
then we calculate, sir, in this case, syntax score.
30, 30. Syntax score is 30. 28. What you do?
Then, if patient is symptomatic, we
Oh, you told that he is class 3? If what? You know, you have seen the patient, no? He is class 3.
then we go for coronary bypass.
Bypass means graft to what?
Graft to Lima to LAD and Lima to LAD and that PDA and obtuse marginal.
Okay. What other choices is? It is class 1 indication for CAPG. ESC guidelines, what it says?
Sir, if patient is
No, not if. You have the patient, you know the angiogram, you tell me what the guidelines says with this patient.
patient having chronic coronary syndrome with grade
We
3
all
in
agree.
China,
Yes, you said it. So according to guidelines, whether he needs CAPG or angioplasty, what the guideline says. See, he has a proximal severe disease, which has a calcium. He has a severe disease in the mid-LAD as well. He has a severe disease in OM. So what the guideline says?
patient is in high risk group, so we so the preferred treatment is coronary artery bypass graft.
Okay, what is class? Can you, classify which class he is? बिल्कुल clear indications हैं, बिल्कुल कोई doubt नहीं है उसमें.
Sir, class 1.
See, Dr. Tiwari gave you the syntax score of 28. When is the indication for cabbage more clear? When are you more sure that you would direct the patient towards cabbage? When are you more sure that results between TCI and cabbage are going to be equivalent? At what syntax score? Can you answer that?
Sir, is patient
If it
having
is 22 or less, then you results are equivalent. So you can have either of the two. If it is
Patient
more
is,
than 33,
if it is 28 and patient is diabetic, then
yeah,
CAPG is more.
then again, the fact that your patient has diabetes, not many, not everybody, I would not say many, most agree, but many do not agree also that diabetes should be a very strong criteria here. But by and large, cabbage is a treatment of choice once your patient is a diabetic of some duration, he is over 10 years.
Do you know any study which addressed diabetic with the coronary artery disease, PCI versus CABG?
No, but the main comparisons just in the cabbage versus PCI groups, the
Abhishek,
diabetic subgroups are the ones which have done better. In
Abhishek,
Yes, sir.
Abhishek, you have to answer Professor Justin's question. Very important. A patient, a diabetic, non-diabetic, which study?
yeah.
Very good study.
Sir, syntax.
Yes, good study.
Yeah.
There
What
is a
about
study.
diabetic population? Any studies in diabetic population?
Only diabetic patients were taken and
Yes.
were subjected to either PCI or CABG. done by a very, very, very reputed person as a first author,
So syntax
not
study.
syntax.
He just wants to get freedom from all these things. And
एक्चुअली अभिषेक सिंटेक्स वो रिस्क फैक्टर को स्ट्रेटिफाई करता है ना 32 लेस देन 32 व्हाट अबाउट 32 तो डू यू हैव सम आइडिया इन डायबिटिक नॉन डायबिटिक रोल ऑफ CABG सम आइडिया हाउ दे बिहेव
Sir, in diabetic population, there is more risk of there is cardiovascular mortality is more in diabetic population, and future cardiovascular event or myocardial infarction or
is there any advantage of CABG in a diabetic
sir, mortality is decreased or future cardiovascular risk event is also less in
as compared to
PCI.
PCI.
Yes,
Okay.
the only there is increased risk of stroke in CABG population. That is the concern in initial days, initial 30 days.
Suppose the patient asks you approximately what percent difference is there in absolute terms. Suppose there is the patients with PCI at 5 years have 70% survival. Then what would be the percentage of patients in cabbage group who will be surviving at 5 years? What is the absolute difference approximately?
Is around
Based on the major
2%.
sorry?
2%.
No. There's a 5% absolute difference at 5 years. 555. Please remember that. There is a 5% absolute difference, means you will have more 5% people surviving in the cabbage group as compared to diabetes.
In this regard, you need to remember a few studies. That is for everybody. One is a little older study, is a Bari 2D.
Yes.
That you have to say.
Yes.
That compares all the three modalities of treatment.
Yes.
Medical treatment, PCI and CABG. Then the diabetic subgroup of syntax and the freedom. These are the few things you need to say in the one breath, because these are the very extremely important studies to guide us in our management protocol.
Yeah. The study that all of us were referring to as the study in diabetic group is actually freedom. So that was the one in diabetic group. Remember.
So what you decide to do in this particular patient, that is just 5 minutes more, if finish up quickly. What you are going to do?
Sir, first we kept the patient on medical therapy and lifestyle.
You just tell the medications, 1, 2, 3, 4, 5.
Sir, anti-thrombotic drugs, tablet Ecosprin, 75 to 100 milligram. We also can add the second anti-thrombotic drug, maybe factor 10A.
Don't say maybe. So you take your own decision. Because you are prescribing, you are taking money from the patient, you prescribe the drug.
I add factor 10A inhibitor, tablet rivaroxaban, 2.5 mg BD, statin, high potency statin, 80 mg, atorvastatin, HS, and diabetic drug, tablet DAPA.
Forget it. The patient has been given anti-diabetic drugs and it is controlled. What else? Then anti-anginal medications, beta blocker or nitrates, long-acting nitrates.
Why you said rivaroxaban? What is the indication in this patient?
Sir, it is a class 2A indication. If patient having high risk patient is having high risk of ischemia and lower risk of bleeding, then it is class 2A indication, aiding with the aspirin.
Which study you are quoting?
Compass trial.
In Compass trial, what was the inclusion criteria?
Inclusion criteria is patient having a stable coronary artery disease and patient is randomized 1:1 ratio with rivaroxaban 5 mg aspirin plus rivaroxaban. In this rivaroxaban is 2.5 mg and aspirin alone. In this trial, it showed that rivaroxaban plus aspirin.
Was it only stable coronary artery disease or something else?
It also includes the peripheral artery disease.
So in this case, why you are going to give rivaroxaban?
Sir, because patient having multi-vessel disease and high risk of ischemia is there. That's why.
So if the patient has no angina with your therapy, you have not done a bypass or you have not done multivessel angioplasty, the patient is comfortable. He is able to do his routine work in the High Court. And what will be your next line of thought? Doctor, I have some blocks. Should we do anything about those blocks? He is asking you.
This is a very, very common question. He will keep on nagging you, Dr. Saab. वो बीमारी का क्या करेंगे जो है उसमें?
Sir, we regularly follow up the patient.
What is your answer? Straightforward. You continue lifestyle modifications or
Yes,
you do revascularization?
Revascularization, we test other non-invasive tests for document of.
I'll reframe the question. I'll continue lifestyle modification. I'll advise non-invasive evaluation and then take a call. What will you do?
Then I advise him to go for coronary artery bypass.
No. What Dr. Justin is saying, is there any other test by way of which you can identify that he's a high risk individual, even in the chronic coronary syndrome group? This is one of the important things made out by this European Society of Cardiology guideline. They said
Sir,
it's heteron.
High risk group are identified by non-invasive test in which stress ECG shows if more than 3% of
Go beyond
mortality.
ECG, dear. Go beyond stress ECG. What tests will you do?
Supposing you have
We look for we do SPECT or PET scan, nuclear imaging, which shows if more than 10% or more of myocardial ischemia, then it indicate high risk. If on stress echo, more than 3 segment or more out of 16 shows regional wall motion abnormality, then it is high risk. If on cardiac magnetic resonance, more than 2 segment shows perfusion defect or more than 3 segment with dobutamine stress shows that perfusion defect. And if on imaging test like imaging test invasive coronary artery angiography, if there is multivessel disease with proximal occlusion or left main occlusion, significant left main or proximal LAD, then it shows high risk feature. And on invasive functional imaging, if FFR is less than 0.80, then it is significant.
Moving beyond our patient, we are only talking about our patient. Fine, you had given the points that, if there is a significant extent of inducible ischemia, then there is a benefit of revascularization as per the guidelines. But as I told you, again, you always need to go back to the stories behind the guidelines. Say, for example, in the SPECT, when you say 10% or more or 20% or more ischemic myocardium, it is based on a study from Siddha Sinai where 10,000 patients were compared to 600 patients who were revascularized. So this particular subgroup alone had some benefit. So, it's an observational study. So they all have their limitations, but then it has not been shown in any prospective study that if it is more than 10%, you are going to have a benefit to the revascularization. These are assumptions that we have based on our expert consensus. Good, all that.
One thing I want to ask you, because time and again this patient will come back to you that Dr. Saab, diabetes ki dawa bhi aap likh dijiye. Please write down the medicine for diabetes.
Dr. Sandeep or anybody, please quickly finish it off. That is, we have already exceeded the time.
I think that would be the last question I would like to ask you.
In this case, we add the SGLT2 inhibitor or GLP-1 agonist?
So which one between the two? GLP-1 agonist or SGLT2 inhibitor? In this particular patient.
And why?
Normal ejection fraction, angina is the major symptom.
If normal ejection fraction is in patient, then I will go for GLP-1 agonist.
Yes, that is the group of drugs which reduce cardiovascular mortality. Correct.
Satyan, last question. I think we have to wind up. All the examiners ask one question each and then we wind it up.
I think it's okay from my side.
I'm done, sir. I'm done.
You're done. Shaura?
So I just want to ask one question to him. In 2007, we had the COURAGE trial. In 2020, we had the ischemia trial. Why was this particular trial necessitated when we already had the knowledge from the COURAGE?
Sir, in ischemia trial, moderate to severe anginal patient, having angina patient are taken in the study group.
Okay,
and this also showed invasive intervention group did not show any beneficial.
No, that is okay, but you already had the lessons from the COURAGE. So that was done in 2007. This is done in 2020. What are the additional points?
And they also use to stratify moderate to severe angina on the.
That is one thing, and another thing is that you didn't have the drug-eluting stents in those periods because drug-eluting stents were just approved towards the end of the COURAGE trial, and here you had the luxury of using drug-eluting stents.
Yes, sir. In COURAGE trial, only 31 patients received that drug.
So ultimately, what is done to the patient? Sandeep, you please sum up and conclude. What should be done to this patient?
I would say that one, I would optimize the anti-diabetic. Number two, keep him on an antiplatelet, as he already said. The role for rivaroxaban may be questionable. I'll keep him on high dose of statin. I'll use beta blocker and a calcium channel blocker for his angina because some of beta blocker plus angina combinations have been shown to be better. I will also like to use an ACE inhibitor as an antihypertensive if needed for its disease modifying property. And then if the patient continues to be symptomatic or nudges me to do something about him, then I would go for a nuclear scan and see what is the area of viability. If it is more than 10%, I would go and tend to revascularize that area.
What modality of revascularization?
Generally PCI, unless, if it's a single vessel, I would prefer to go for PCI. Otherwise, multi-vessel, I would go for CABG.
And I think you have summarized it, what should be done to this patient. And I thank you, everybody, all the participants, Abhishek and all the 4 examiners, Sandeep, Dr. Tiwari, Justin, and Shaudo, for asking this wonderful questions. And we should come to the end of this. We are coming to the end of this session because we have another subject left. That is a talk on cardiac MRI by Johan Christopher. Johan, you are here.
Morning, sir.
Please,
morning, everybody.
you please start your deliberation, and this will be for 45, up to 45 minutes you can take.
Right, sir. Okay, sir.
Abhishek, you please unshare your screen, and
Yes,
Johan,
sir.
you start sharing.
Yes, sir. Thank you, sir.
Thank you. Thank you, all of you. And thank you, Abhishek. You did a good job. Thank you, my fellow examiners, and thank you, Guha, sir.
Sir, can I start?
Yeah. It's all yours.
Thank you, sir, again for the kind invitation. And I'll be talking about the role of cardiac MR in cardiology practice with all live examples so that the students can understand the utility of using this technique. So I'll just start with a couple of MCQs just to get everybody started off. I will give these answers at the end of the talk so that you will know how much you have understood. So the first question is, what is the role of MRI in heart failure? Assess morphology, characterize the cardiomyopathy, risk stratification, or all of the above. The second question is, viable myocardium is defined as a scar greater than 50%, less than 25%, less than 50%, or none of the above. What is the role of delayed enhancement on MRI? Does it indicate increased clinical events, increased risk of arrhythmias, evaluation of etiology, or all of the above? What is the scar pattern in sarcoidosis, which is an inflammatory cardiomyopathy? Is it subendocardial, epicardial, mid-myocardial, or all of the above? What is the condition with a low T1 value? Is it Fabry's, amyloid, HCM, or all of the above? And what is the condition with a high ECV value? Fabry's, amyloid, HCM, or all of the above? So these are the questions. If you can just make a note, and we will answer them when I complete. So thank you, everybody. And this is from Hyderabad, and this is our imaging center at CARE Hospitals. We do understand in 2008, a very nice Times of India article came out as chronic diseases to bleed India. And we see that happening right in front of our eyes today. And we know that chronic diseases like ischemic heart disease extracts a very high cost. It is also very pertinent here to know that the symptomatic patients that we see in the outpatient are only the lip of the iceberg, and the actual disease is very well hidden. Chronic coronary artery disease, as we know, has a very significant goal to increase event-free survival, to improve global LV function and relief from angina symptoms, as you saw in the last case. And it's very important that we need to know whether the revascularization is necessary and also the technical feasibility. So the imaging lab has a number of components. The stress may be the dobutamine, coronary angiogram, cardiac CT, and today we'll be talking about cardiac MR. Why MRI? If you look at the competing technologies of echo, you will see that morphology and function are high on the charts. And if you look at nuclear, again, function is good, metabolism is good, as with PET. And CT is very good with morphology and really nothing else. But it is only MRI which encompasses the entire realm of morphology, function, tissue characterization, and metabolism. And that's the reason why we would pick MRI as a very, very important tool in the evaluation of cardiovascular diseases. Among the top 5 indications in MR, the first is obviously advanced ischemia detection when other tests are equivocal. Heart failure is possibly the most or second most important, especially in our country, where we have a lot of the non-ischemic cardiomyopathies, which we will be talking about. Electrophysiologists will agree that MR is a very important tool in the pre and post-op, and cardiac function, we know, is a very essential way of how we practice cardiology, and whether you want to put a device or you want to prognosticate the patient, the ejection fraction is very, very important, and MRI delivers it as a gold standard. In congenital heart disease, MR is invaluable we'll be touching on a few examples today about that. The technique is complex. It's very important to know that there's really no preparation except that in a male patient, chest hair have to be removed, and you need to make sure that the patient does not have a iron metallic device, either an implant in the eye, the brain, or in the initial models, any intracardiac device. However, in the conditional MRIs, we are doing patients with ICD, CRT, as well as pacemakers. But I must tell you, the pictures are not that great. And I would use another technique if it was possible, if I have a patient with any of these implants. However, if you have a steel plate or a steel rod in the leg or hand, within safe concerns, you can go ahead with a cardiac MRI. The other preparation which is important is that the patient should have a normal creatinine. We generally don't do a cardiac MR if the GFR is less than 40. We have special contrast called cyclic gadolinium, which we have got fairly recently from GE, where we can go up to 35, but nothing lower than that. Any patient with CKD or a dialytic patient, we must choose a technique other than the MR. The nuclear techniques are generally preferential. The positioning involves putting a non-ferrous ECG lead. These are special ECG leads. They're expensive, so they need to be carefully used. Getting a good ECG signal with a good application to the thorax is very important, so that really makes the technician and the nurse's job very good, because a good ECG signal will give you good pictures. Breath hold is very important, and most of the sequences are breath hold sequences. We can get away without breath hold by using navigator sequences, but they are expensive and they also take a lot of time. So training the patient to breathe well is a very important part of the MR examination. Generally, if patients meet me a day before, I tell them to lie down at home in a dark room and practice counting up to 6. Generally, the sequences are up to 6 to 10 seconds. And when they come to the MR room, they're very, very comfortable in doing that. Sequences, we have 3 main sequences: the Csi sequence, the T1, T2 maps, and the inversion recovery, which is usually done post-gadolinium. The contrast that we use is IV gadolinium, and we use around 20 ml of contrast for an average adult, and for a child, it is between 8 to 10 ml. I've already told you that NSF, or nephrogenic systemic fibrosis, is a dreaded complication post-gadolinium, especially if you give large volumes, or in a patient with liver failure, or in a patient with a GFR less than 30. Now, if you look at heart failure, the role of imaging here, the first role is to tell us whether the ejection fraction is less than 40 or more than 50, what we call a HFrEF or a HFpEF. And we also know that the survival of these patients are markedly different based on the ejection fraction. We have a number of tools like the MIBI, the MUGA, the LV angiogram, we talked about it in the last case discussion, echo, and the MR. But MRI is the gold standard for ejection fraction as of now. And you can see the lower right-hand data set that I have put in. You can see that you have 8 slices right from the base to the very last, the apex. And all this is planimetered, and you get a very good volumetry, which is very accurate. You get the mass, you get the end diastolic and systolic volumes, you get the derived stroke volume and the cardiac output. Currently, it is the gold standard for ejection fraction, both for the left ventricle and the right ventricle. 3D echo is a very close competitor, but MRI really scores. If you look at the 2013 appropriate utilization, you will see that whether the patient has a mildly reduced LV function or a severely reduced LV function, cardiac MRI is the very, very appropriate tool for the evaluation of left ventricular function. The next problem in heart failure is whether the patient has coronary artery disease or not. And it was usually in the past evaluated by a coronary angiogram. And this is Felker's data way back in 2002, which clearly showed us that the ischemic subset had a poorer prognosis compared to the non-ischemic subset. And generally, in practice, we have been utilizing the coronary angiogram, a normal angiogram on the left, and a patient with an occluded LAD on the right to deduce coronary artery disease. However, MRI has its own tools, and if you look at the patterns of delayed enhancement, you will know that the patient in A is a patient of ischemic heart disease because the delayed enhancement is got a subendocardial distribution. And we know from the wavefront theory that the infarct progresses from the subendocardium to the epicardium because of the distribution of coronaries. The positions at maximum risk is the subendocardial region, and therefore the infarct starts from there and goes outward. Whereas in the myocardial diseases like dilated cardiomyopathy, there is no vascular involvement and you find a mid-myocardial distribution with sparing of the subendocardium. The same thing is seen in patients with hypertrophic cardiomyopathy, where because of the disarray of fibrils, you have the patchy delayed enhancement in the septum. And this is also what you see in patients with myocarditis. They have more of an infralateral wall extending up to the epicardium and also touching the pericardium in myocarditis. And in patients with sarcoid, you have a patchy involvement, especially involving the septum. And the only other patient other than ischemic heart disease which has a subendocardial involvement is patients with amyloidosis, and they have a global subendocardial pattern, and it's a very important pattern to distinguish, and we'll be talking about that a little later. So MR has the attribute to evaluate coronary artery disease as well. If you look at the 2009 ACC/AHA guidelines, you will see that non-invasive imaging in heart failure has a 2B level of evidence C, and I think that is a good thing because it is quite appropriate for the use of this technique in these patients. Now, if you look at cardiac MRI here in the center, you will see all the diseases that can be evaluated, which we have just talked about, and therefore cardiac MRI is a very central and important tool in the assessment of these diseases. We'll first talk about coronary artery disease and the role of cardiac MRI. So as we saw before, we look at the wall motion, a stack of 8 images. We look for normal, hypokinetic, akinetic, and dyskinetic segments. We then look at the west myocardial perfusion, as you can see in the data set that I'm showing you. And you will also see here and appreciate that there is a lot of areas of black here in the anterior septum compared to the grayish in the rest of the area, suggesting that there is decreased myocardial perfusion in the LAD territory. The third thing we look at is the data set post-gadolinium, and that is the data set of gadolinium enhancement here in white. And again, you can see here that this patient has had an LAD infarct. What is very pertinent here is that we look for no delayed enhancement, less than 25% delayed enhancement, 25 to 50%, and more than 50%. Any delayed enhancement more than 50% is considered non-viable. We also are able to do coronary imaging with the latest 3T MRIs. The images take a long time. It requires a lot of training. However, we can get these pictures if the patient is an appropriate patient. So coronary imaging is also possible. Then we put all the data together and we get the wall motion, we get the delayed enhancement, and we put both of them together. As in this patient, you saw that the patient had an akinetic wall motion in the mid and distal segments and apex. There was also more than 50% scar in these segments, and therefore these segments were considered non-viable, and these happen to be in the LAD territory, as you can see, and this is suggestive of a patient with an LAD infarct. We can also evaluate complications post-MI, and this is a patient with a left ventricular aneurysm and a thrombus there here. The thrombus can also be seen better in a post-gadolinium enhanced image with a TI of more than 600, and you can see the thrombus very well over here. And gadolinium-based MRI has a sensitivity and specificity of over 90% for the detection of LV thrombi compared to T and 2D echo. An interesting complication of a patient with an OM infarct or OM occlusion, and this patient developed chest pain 2 days after the MI. He had a pericardial effusion on echo and he was sent to us. We did the MRI and you could actually see the tear, serpiginous tear of the myocardium with contrast flowing into the pericardium, suggestive of a myocardial rupture. And this patient was fixed in the CT theater and had an uneventful recovery. Now, these are some pictures to show you the kind of delayed enhancement that we see. This is a patient with a subendocardial scar in the LAD territory. You can see that here. The arrows are pointing to the white thin line here. And this scar is less than 50%, suggesting viability. And this is a patient with a delayed enhancement in the same anterior septum. And you can see here that it occupies more than 50% of the space and therefore is a transmural scar and therefore is non-viable. This patient has again a transmural scar in the infralateral and posterolateral wall, and this is suggestive of transmural scar in the L6 territory. Another patient again with a near transmural scar in the infralateral wall, and this patient would have a non-viable L6 territory. This is a patient with a 25 to 50% scar here in white in the same infralateral wall, and again this patient would have a viable myocardium in the L6 territory. And this is another patient with a transmural scar involving the inferior wall, and this would have a non-viable RC territory. Shifting gears and moving on to valvular heart disease, and where does MRI sort of hang in there? In the 2017 guidelines published in the JASC, which is the echocardiography, it was clearly shown that the American Society of Echo for the first time did a collaboration with the SCMR, which is the Society for MR, Magnetic Resonance, and they did a joint recommendation, and this really shows how MR is very important in the evaluation of valvular heart disease. In aortic valve assessment, you know that the aortic valve is very well evaluated by transthoracic echo, but in situations where there is a lot of calcium and distorted valve, we can do a very nice planimetry of the aortic leaflets and therefore get the stenotic area as well. This is especially true if you have a very calcified valve like this. This does not deter us from evaluating because in MR calcium is really not seen. So therefore we can have a very accurate planimetry of the valve. But it is truly in regurgitant lesion with MRI really shines, and this is a patient with a severe aortic regurgitation. You can see here the amount of blood regurgitating. And what we do on MR is that in a short axis view, we quantify the blood flowing through the ascending aorta. And during this, with what is called a velocity encoded image, this is the picture we get. We get the forward flow of the blood going through the aorta, and we also get the blood coming back, the regurgitant flow, and therefore we get the regurgitant fraction. And this is a very, very accurate way of assessing aortic regurgitation and would possibly be more accurate than what 3D echo can give you, because it does not depend on the plane, it does not depend on the angle of the regurgitation jet or the Doppler angle. Now, mitral stenosis, as you know, is evaluated by transthoracic echo, which is possibly the gold standard, but studies have come in patients with, again, distorted valves or patients with equivocal studies on the 2D echo. We can get a very good planimetry of the mitral valve. As you can see, these four sections, we can actually get a very good planimetry of the mitral valve on MRI. And you can clearly see that the mitral valve evaluation by CMR and with transthoracic echo are fairly equal. Again, mitral regurgitation, regurgitant lesion, very well evaluated by MRI. We know the problem of eccentric jets. It's very difficult to evaluate it by echo and requires a lot of expertise. But here there is no problem. The other thing is also the mechanism, especially if there is a scar in that area and you're thinking whether revascularization versus putting a ring or replacement. MRI gives you the information. If the patient has a scar in the infralateral wall and there is complete akinesia, it means that revascularization alone will not take care of the MR. The patient has to have a mitral ring as well. And what we do here is we look at the LV stroke volume. This is in diastole and this is in systole. So we deduct the systolic volume from the diastolic volume. We get the stroke volume of the LV, as you know. And then we look at the flow going through the aorta, as I showed you in the last picture. I'll just take you back. We look at the flow going through the aorta, and this is the forward stroke volume. So the total stroke volume, as was deducted by the end diastolic and end systolic, subtracted from the aortic flow, will give us the backward flow going into the left atrium. And this is the regurgitant flow that we get, and anything more than 40 is severe. So here, with a little bit of mathematical calculation, you get a very, very accurate regurgitant flow, and it does not depend on the Doppler angle and the experience of the operator. It's pure mathematics. Now, what about pericardial diseases? Now, this picture, as you will see, has a couple of interesting things to show us. One is it shows us that there is a thick pericardium, but what is also important, it shows us there is a septal bounce, which clearly illustrates the concept of interventricular dependence, suggesting that the patient has a significant constrictive physiology. But what is more important, and this is also given by Trudy Echo, is that post-gadolinium, we find that this patient has significant gadolinium uptake, suggesting that the wall is not only thick, but also inflamed. So these are the patients who have a significant gadolinium uptake. We give a 4 to 6 weeks of steroid to let the inflammation die down and then reevaluate these patients. And in about 30% of patients, depending on the study you look at, there is actually significant cure of the constriction, and therefore the patients do not need pericardial stripping. However, if the patient has a sizable pericardial thickness and no gadolinium or little gadolinium enhancement, and a very good cleavage line between the pericardium and the epicardium, these patients do very well for surgical stripping. So this is another patient who has a mixed picture. There is fluid here in white, and there is thickening of the parietal pericardium, and also thickening of the visceral pericardium here in black. And these are patients who have a mixed physiology of effusive constrictive pericarditis. There's another patient who has the typical biatrial dilatation, small ventricles, thickened pericardium all around. You can see that here. And what is more important, we do a CT scan, which is very specific for calcium, and we find that there is almost a calcified shell around the heart. And these are patients at very high risk for surgery, and you need to be very careful because they tend to bleed quite a bit. This also is an indicator of a tuberculous etiology. Moving on to congenital heart disease. The classical thing that we get as adult cardiologists is this kind of patient, a patient post ICR for evaluation of RV function, RV volumes, and pulmonary regurgitation. And here you can clearly see here that this patient has a markedly dilated RV. There is free pulmonary regurgitation, and we are estimating the flow of the pulmonary blood coming through. You can see this dark area which is just flooding back, the same thing going on here. And what is more important is we are able to quantify this. And if you look at the two red arrows, you will see the regurgitant flow is 49.5 compared to a forward flow of 133. And that leads to a regurgitant fraction of almost 37%, which is very, very significant. So we are able to look at the RV function, the RV volume, and the regurgitant fraction, which is very, very important for the percutaneous or surgical implant of a new pulmonary valve. Extracardiac anomalies, again, are very important, and coarctations sometimes can be missed, and the severity can be questioned. So this is a very good example of a coarctation on the contrast as well as on the flow, clearly showing that this is a significant coarctation. And the interesting thing that we do here is not only look at the pre and post and the quark segment, but we also look at the flow here in this picture at the diaphragm and at about mid-level here. And we find that there is a significant increase in flow here. We know this coarctation is important, even though it may be borderline in terms of significance, because if the flow at the diaphragm is very high, it means there is a lot of collaterals which came away from here and then entered over here, suggesting that the coarctation is very significant. This is a patient with a TOF with a difficult to evaluate central aorta with the straddling of both the valves. And here it is very important because here we can assess the shunt over here, and also we can see the bypass thing that needs to be put over here. And this again is to evaluate the pulmonary outflow tract. And this is a patient with a PA-PVC. You can see the right inferior pulmonary vein entering into the RA-SVC junction, very clearly seen, and this sometimes can be missed on echo. And this is again a difficult to evaluate sinus venosus ASD. Quickly move on to non-ischemic cardiomyopathies. We've got about hopefully 5 minutes here, and you can clearly see that there are a number of non-ischemic cardiomyopathies. What is very important to tease them out is that each of them have a different estimate of survival. The best estimates are with pericardium cardiomyopathy, and the worst are the ones with HIV infection. And there's a whole lot of cardiomyopathies with intermediate estimates of survival. So it's very important to tease these out, and MRI possibly is the best technique today to evaluate cardiomyopathies. If you look at the blue and red bars, the blue indicates the presence of gadolinium and the red is the absence. It clearly shows that irrespective of the cardiomyopathy that you look at, if you have any amount of gadolinium, the all-cause mortality, the heart failure hospitalization, and the sudden cardiac death markedly increases, which is statistically significant by a factor of at least 3 in these patients. We do understand that there's a whole host of myocardial pathology, and therefore, when you take them to the pathology lab, you have different stains for different pathologies. But here we have developed what is called a single stain, and we call this the T1 mapping technique, which is fairly new, and it is freely available now in this country with the 3T MRIs, and basically looks at the myocardial relaxivity properties. So the diseases which have a low T1 and an ECV are the lipomatosis metaplasia. This is usually seen in chronic infarcts of more than a year, and where there is fat distribution like a lipoma. They have the lowest T1s and the lowest ECVs. Moving on to Fabry's disease, which has a low T1 and ECV, and iron deposition. So these are two cardiomyopathies which have low T1 and low ECVs. The hypertrophic group, DCM, also have intermediate T1s and ECV. Myocarditis has an extremely high T1, also the systemic sclerosis. But the highest T1 is with an acute MI, especially when you visualize them within about 5 to 6 days of the MI. That's when we get to see them. Also, what is more important is that we have the highest T1s in AL amyloidosis, followed by ATTR, and the highest ECV in ATTR amyloidosis, followed by AL1. So when you get a cardiomyopathy which fits in the phenotype of amyloidosis with a very high T1 and an ECV, consider this as diagnostic of amyloidosis. The ECV can be calculated through a complex calculation. We do the T1 before gadolinium contrast, we give the contrast, and then we do the ECV estimation based on this very complex calculation. The hematocrit is compulsory for these patients. So MR today can give you the cine, wall motion, ejection fraction. It can give you a non-invasive T1 map without gadolinium, and based on the T1 values, a whole host of disease we can see. You can see these patients post gadolinium, and that gives you an estimate of their survival and also sometimes the etiology. You can construct an ECV map based on the T1 and the gadolinium, and the ECV again has very important prognostic value. And you can also do a perfusion map with the gadolinium, which tells us about the underlying ischemia. So MRI encompasses a whole host of attributes of the myocardium. This is a patient with a myocarditis, LV dysfunction, LV is dilated, and patchy scarring, especially involving the infralateral with some involvement of pericardium with pericardial effusion, very classical for myocarditis. And what you do see is a very high T1 here, and also a mildly elevated ECV with the gadolinium enhancement exactly in the same area. So high T1s in the infralateral area are usually suggestive of myocarditis. And this is an important thing for us because these are patients who are young, they present to the emergency room with chest pain, and they have TROP2 positive. So myocarditis is a very important thing to be ruled out, because if we take them to the cath lab and give them heparin, they bleed into the cath lab. This is a very interesting data set of a patient with non-compaction. The diagnosis here is made in end-diastole in MR as opposed to echo. And the diagnosis is made if you have a non-compacted segment or a spongy segment more than 2.3:1 in areas other than the apex. So that is very important. And this data set of 8 pictures will rival anything what 3D or echo can give you. And this is the diagnosis. So you have to make the diagnosis in diastole with a 2.3 spongy versus 1 of compact. Sarcoidosis is another entity. It's an inflammatory myocardium. They have regional wall motion. They have a LV dysfunction, sometimes even an RV dysfunction. But what they do have on this scar is a typical midline septal scar. And this is very, very diagnostic. In addition, the third entity that you get is significant mediastinal lymphadenopathy. And here we have a large series of patients which we have published. The presence of delayed enhancement tells you that these patients are going to have a high all-cause mortality, significant tachy and bradyarrhythmias, and will require some kind of a pacemaker or ICD. We also use PET scan in these patients because many times we put an ICD after the MR is done. And this is a patient in 2015, quite significant FDG uptake. You can see that in the myocardium and also in the mediastinal nodes. In 2018, after a course of steroids and immunosuppressive medication, this is the picture that we got. There is hardly any mediastinal uptake, and the myocardium is all nice and cleared up. This patient had a significant resolution of the ventricular tachycardia and improvement of ejection fraction. And this is our paper that we published, where we found that patients with preserved LV function with ventricular monomorphic arrhythmias had a significant number of sarcoid and tuberculosis, which responded to disease-specific therapy and antiarrhythmics and did not require devices. The future, obviously, is PET-MR, and the disease which is best suited for evaluation is sarcoidosis, where you have an MR picture here showing the scar, the PET or maybe picture showing the decreased perfusion, and the MR and the PET fused, showing the inflammation here and the scar over here. And this would be the future. There are only 2 centers in this country which currently possess the PET-MR and are doing active cardiac studies. Now, this is a typical patient with restrictive cardiomyopathy, the biatrial dilatation, IS hypertrophy, a significant concentric hypertrophy with mild LV dysfunction, and a septum which is extremely sluggish, and minimal or no pericardial effusion and normal pericardial thickness. And this is a typical prototype of an RCM. And when you look to the right, you will see the typical distribution of gadolinium in a subendocardial global fashion. And this is sine qua non of amyloidosis. In addition, if you find the patient having a high T1, the gadolinium enhancement, which is circumferential and subendocardial, and also a widely increased ECV in red, this is again sine qua non for amyloidosis. And you do not need to do a biopsy in these patients. You can straight away do what is called a pyridicium scan, which is a nuclear scan, and that will tell you whether there is ATTR or it is AL amyloidosis, and then can be treated accordingly. Now, this is a data set for a patient who had amyloidosis, thickened ventricles, gadolinium, and a high ECV. And after treatment, and we know that there are good molecules like bortezomib, and of course stem cell therapy in AL amyloidosis, and a number of molecules which are covered for TTR amyloidosis. 1 year down the line, when we image this patient, you can see the thickness has come down, the gadolinium enhancement has more or less gone away, and the ECV is near normal. So MRI can actually guide the treatment of amyloidosis. What is also pertinent in terms of prognosis, if you have a high T1 more than 1044 or an ECV of more than 0.44, these patients have a high risk of death and heart failure hospitalization. We diagnosed thalassemia in the past by liver biopsies and also by ferritin level. So high ferritin level and a liver biopsy which was positive meant the patient had an iron overload. But we do understand that with the MR, we know that the patient with the same 1033 ferritin level can have actually a lot of iron in the liver, which is a better prognosis. And the same ferritin value can have a patient with no liver iron, but a lot of myocardial iron, which has got a poorer prognosis. And therefore, the myocardial assessment of iron is very, very important. And the T2 star is a kind of a myocardial relaxivity property. And the lower the T2 star that you get, the higher the iron content that you're going to have. So the T2 star is what we call the INR of iron on MRI. And irrespective of the ferritin level, it gives you the exact iron deposition in the heart, and therefore enables these patients to get treated early. They get IV desferoxamine early, and they get multiple doses of it, and they actually do well. Fabry's disease is a disease where you suspect when there is a concentric hypertrophy, there's more of infralateral hypertrophy in a patient, and you get the alpha glucosidase level, which is elevated. And MR can look at all the stages of Fabry's, including the low T1. In fact, it's a cardiomyopathy with a low T1, unlike HCM, which has a higher T1. And also there is some amount of decreased ECV in these patients. This is a patient with DCM, you can easily see that. But what is important is this patient has a scar, and the presence of scar allows these patients to have a worse prognosis, and these patients also have a higher ECV, and that's how we make the diagnosis. And also by the presence of scar, you can clearly see patients with scar and patients with no scar, same DCM, same volume, and the moment they have a higher scar in black, their 5-year mortality, all-cause mortality is higher, their cardiovascular mortality is higher, their heart failure risk is higher, and the sudden cardiac death is also higher. This is a patient with PPCM. I told you it's a good prognosis. Patient presents just like a dilated cardiomyopathy, but there is absolutely no scar, and these patients have a better prognosis. In patients with RV dysfunction, dilated AV, we would like to make the diagnosis of ARVD, especially if they have a family history, especially if they come either with arrhythmias or they come with heart failure, which is not amenable to treatment. And here we have the 2010 guidelines, the revised guidelines, which clearly puts a number. If you have an EF of less than 40 on the RV side and an RV EDV of more than 110 mLs by body surface area, these patients, you can make a major diagnosis of ARVD and you can treat them appropriately. And these are MR pictures of the ARVD showing the triangle of dysplasia in systole, showing that the outflow tract aneurysm, the inflow tract aneurysm are very classical of ARVD, and also the presence of a dilated and dysfunctional RV should make you suspect ARVD. This is a patient of hypertrophic cardiomyopathy. As you can see, the markedly thickened septum, the SAM with mitral regurgitation, dilated LA. But the additional information that we get on MR is post-gadolinium. You see the patchy scar here in the mid-septum. We talked about that, the mid-septum. And now by quantification of the scar, if you get a number of more than 15%, you are eligible to put an ICD, although it has not come into the guidelines as yet. These are patients with a high T1. These are patients with gadolinium enhancement, and also patients with a very localized increased ECV. And that really helps us make the diagnosis. Another example of patient with HFpEF is patients with endomyocardial fibrosis, where they have a normal LV function, normal RV function, but they have the apex obliterated, and on gadolinium enhancement, they have the typical arrow shape of the apex, and this suggests that there is a fibrous component. Moving on to cardiac masses, if anybody can unmute your mic and tell me what this is. You can see that this is the LV, RV, LA, and RA, and this is a large mass abutting the lateral wall. And post-gadolinium, you can see the clear cleavage line and the multiple numerous septae. So for those of you who have not seen this, this is a case of hydatid cyst, and the presence of cardiac MRI has an A9, that is a highly appropriate nature for evaluation of cardiac masses. And this is another cardiac mass. As you can see, this is the cine picture, large sessile mass arising from the apex and protruding into the LV inflow, causing a mild mitral regurgitation as well. This is the still picture showing you, and this is the delayed picture. And here is a T1 of more than 600. So that should give you a clue. And this was nothing but a thrombus, an LV thrombus arising from the apex. And the reason for the thrombus was, you can see the delayed enhancement here in the anterior septum and apex, a patient with an LAD occlusion. Later we did the angiogram and found the LAD to be completely occluded. So concluding, my dear students, the evaluation and management of patients with heart disease is clinically challenging. What is essential to the appropriate management of these patients is you must understand the underlying cardiac morphology. The function is important. Ejection fraction is a very important parameter. It's very important to identify the pathologic and modifiable substrate in order to treat these patients in a more cost-efficient manner. Thank you very much.
Thank you, Johan. Excellent talk, because very, very informative. I think Satyan is there. Praful, are you here? Rakesh is here.
I'm very much there. Praful here, yeah.
Yeah, but any comment? Rakesh, Praful, Satyan, anybody?
Yeah.
And the students can ask questions in the chat box. I will read it out, and Johanvir is there to answer. If there is any question on this, you can just write in the chat box.
I think that's a very informative and very elaborate presentation on cardiac MRI. And there are a few indications like the connective tissue disorders and extra cardiac masses, where it is very useful imaging tool for diagnosis.
Rakesh, any
Yes.
comment? Anything?
Yes. John, there's one important question. Now, everybody is sending SCM patient to MRI, whether they are symptomatic, asymptomatic, obstructive, non-obstructive. And majority of the place where MRI is done, they are not giving quantitative assessment of LG. So is it useful for a common public, for a question, that if you cannot do a quantitative assessment, should MRI be done in these patients or not?
Yes, sir. Very good question. Actually, the software for the delayed enhancement is there in a few centers.
Yes.
And
Rakesh, your
electrophysiology.
voice is not clear.
Okay, no. But
I understood the voice. I will just repeat his question. Dr. Rakesh said that most of the centers are not quantifying the gadolinium scar and sending patients with just a very brief report. Well, that is true. Most centers are not doing it. As you know, as electrophysiologists, we have now begun to understand that 15% is a very, very important number. And in a patient with an equivocal clinical and equivocal presentation, more than 15% scar puts these patients at very high risk for sudden cardiac death, and is allowing electrophysiologists to move into placing ICDs in these patients. It does not come in the guidelines, but we're hoping maybe end of this year, we should have it in the guideline. It's very sad that despite the proliferation of a lot of software, most people do not put that number on the report. However, because we do not live in a perfect world, I think it is very important that the mere presence of gadolinium in a patient who otherwise would not satisfy an ICD, I think should at least make us ask that person that, can you at least make some attempt? As a clinician, we need to make that attempt. Or when we send these patients to the lab, we should check with them, are you doing quantification? And if they are not, then there is always another lab which does it. So I think a lot of responsibility comes as clinician when we are sending these patients to make sure you make that question. So if I'm an imager and I'm not doing quantification, I will clearly tell the patient, no, I'm not doing it, please go elsewhere. I think that's the way we can slowly get our imaging community to start doing it, which is important.
Yes, John, that is a very important message which I want to give to everybody. We don't do an MRI like left and right, which has been done in many of the centers. And second important thing, John, what we are seeing, that ARVC is now very important entity in this country. Rhythmogenic right ventricle hypertrophy. And we are seeing a lot of cardiomyopathy. We are seeing a lot of patients who are presenting with RVO-TVT. And if you send to the MRI center, they will mention normal. But if again it is being read by some good person, they say, no, there is a suspicion. So is MRI reading in a subtle case of ARVC is very important or not? The message need to be given very clearly. That left and right people are reporting it normal.
Yes, I will just share one screen so that we can just sort of look at this particular point, because this is a very important thing here. And this is the 2010 recommendation, guideline 2010 task force. And I think it is very important that we look at this. I'm just going to just share this screen, just so that for the benefit of our audience. And is it visible?
Yeah.
Yeah. So this is a very important thing. I think, again, when we send a patient to an imaging person, and we are suspecting ARVD because of two reasons. Either they have a very typical arrhythmia, or they come with heart failure with a dilated RV with dysfunction on the echo. And if you look at the revised task force criteria, we need to have numbers from the imager. And the numbers are as follows. You need to have an RV EDV of more than 110 ml per meter square for a male, or more than 100 on a female. And you need to have an RV ejection fraction of less than 40%. And this constitutes a major criteria, because in fact, we have been seeing a lot of patients who are referred to us for ARVD, and 60% of the time we actually say it is not. This is very important, because if it is not ARVC, a lot of work can be done by the electrophysiologist in terms of ablation and get these patients back, both in terms of RV function and RV failure. However, if it is ARVC, there is only one role, that is the role of an ICD in this patient, because it's not a very high thing. So this differentiation, I think, has to be made. And again, I think there's a lot of thing on as clinicians, that when we are sending these patients, we need to quantify the RV. And that will again allow a lot of the imagers who who are just giving some of these very pedestrian reports to either modify themselves or they actually lose the business. This is just my practical thoughts, which I've been seeing for the last 10 years.
Rasool, any comment?
Yeah, excellent talk, Johan, and overall
Please show the video, man. Can't see your face.
not very presentable. One second.
Okay, carry on.
One second. Here, I'm in a t-shirt and stuff like that.
That doesn't matter. You're looking smart.
Thanks, Johan. Excellent talk, and overall a good clinic. I was there throughout the clinic. Only thing is that, meaning we need to get our students to answer to the point and fast enough. He was very good, that session was, and come forwards. Today, we do not have a time limit as such. We need to understand at exam time, there is a 45-minute period only. And it is different that this is a different kind of a teaching class, but answer to the point and get to the next question as fast as possible. And also, obviously, as a moderator, Dr. Shantanu is there to tell Baba examiner, don't spend so much time on history, don't spend so much time on investigation, so much time here. So that is one thing. And as far as Johan is concerned, about amyloid, radionuclide first or CMR first? Because I recently attended a session wherein we all of us, radionuclide for amyloid, we remain really in the dark. We don't really, as cardiologists, we collaborate more with the with the CMR guys, and therefore we'll end up doing CMRs first. But actually, in the algorithm, the bone scans become very relevant for ATTR amyloid. What's your take on that?
Yes, sir. Actually, I'm in the middle of, or almost completing a sort of a small capsule on amyloid. And our take is that you need to do echo, and where there is a suggestion, we need to go for a cardiac MRI first. The cardiac MRI will address the phenotypic part. That is, it will tell you that this is a heart failure with preserved ejection fraction. You have the biatrial dilatation. It will address the regurgitation. It will address the thickening. But what it will also do is give a histological confirmation two ways. One is if you have the classic gadolinium, which I showed is subendocardial. But what is even more important is the T1 mapping seems to be even better, more sensitive. You have high T1s and you have a high ECV. Now, this kind of a thing, when you put it together, combination is very, very specific for amyloid. And you can almost do away with an endomyocardial biopsy. Once you get that information, both on the gadolinium and on the morphology, the next step is to whether it is AL or ATTR. And that is when you do a pyrophosphate scan by the nuclear guys. The pyrophosphate is very specific for ATTR amyloid. And if it is positive, you go down that pathway and address this patient with multiple drugs. As you know, there are good drugs in the market like terfenadine and butrazomin. However, if the pyrophosphate is negative, then you need to move towards the bone marrow and then pick up AL amyloidosis, which is very, very amenable to a stem cell replacement. So I believe it is always MR first, confirm the phenotype, address the gadolinium, address the T1 and ECV, and then the next step for further characterization becomes the pyrophosphate scan, which is a nuclear-based scan. The pyrophosphate scan, again, is expensive. People club these over 3 months cases and then do them. So they're not going to be just waiting for you to send your patient. There's a long waiting time in most places. So the MR is very easily available, and you can actually start treating them as a cardiologist before you can get to that pyrophosphate scan. The pyrophosphate scan is mainly to differentiate the AL and the ATTR, and then thereby help the hematologist or oncologist to take care. So my take is always MR first.
Yeah, because the argument was that pyrophosphate scans are cheaper and interpretation is not there is no operator required to interpret as such, meaning it's not the man behind the machine as far as pyrophosphate scans are concerned. And again, AL versus ATTR goes mainly to the other kinds of investigations that you do, hematological and urine examinations that you do, AL versus this. So somehow in the algorithm, even I was of the opinion that CMR first, I was thinking, but in that session, people were talking about pyrophosphate scans as being all important. In the algorithm that they had created, whichever society algorithms these were, they were talking about a pyrophosphate scans before CMR. So that's what I was just trying to ask, whether CMR just becomes complementary or in the algorithm CMR comes later for amyloid. I got educated on those lines in that particular seminar that I was together with a cardiologist as well as a radionuclide person as well as a CMR specialist from the country. Anyway, excellent talk.
Okay. Thank you, Johan. Thank you
so
very much. It was a wonderful talk and a very good discussion.
Is this recording available for students or for teachers also? Meaning that would be very nice because this is CMR in a nutshell,
Yeah. Okay. But even if it is not available for others, it will be available for you, Praful.
Oh, yes, I would love to. I would love to have it. Yeah.
I'll personally send you my PowerPoints, so no problem.
Yeah, even your talk recording itself is great.
You'll get it.
Push up on your CMR.
I'll send you across.
Yeah, thank you.
So,
thank you.
Thank you very much. All the examiners, Abhishek and Johan for the session. Initially, we had a very good session on chronic coronary syndrome, as Praful has already summarized it. And Johan, you gave a very good glimpse of the present status of the cardiac MR. Thank you very much. And we conclude the session today with a note that we'll be having the next master class on 16th of May. And this will be on there will be a clinical case discussion on a case of restrictive physiology. It may be a restrictive cardiomyopathy or it may be a constrictive pericarditis, depending on the case. And there will be a talk on nuclear cardiology. So till then, thank you everybody and goodbye. Stay safe.
Thank you so much, Professor Guha.
Thank you.
Bye.
Bye.